Anticoagulant medications are used to prevent blood clots from forming. These medications work by interfering with the normal function of plasma proteins called coagulation factors, which take part in secondary hemostasis. But let's focus specifically on the anticoagulant warfarin, which works by preventing the synthesis of coagulation factors 2, 7, 9, and 10,
and anticoagulation proteins C and S.
Now, to understand the regulation of clot formation, we first need to talk briefly about hemostasis, in which hemo refers to the blood and stasis means to halt or stop. Hemostasis is divided into two phases, primary and secondary hemostasis. Primary hemostasis involves the formation of a platelet plug around the site of an injured blood vessel, and secondary hemostasis reinforces that platelet plug with the creation of a protein mesh called fibrin. To get to fibrin, a set of coagulation factors, each of which are enzymes, need to be activated. These enzymes are activated via a process called proteolysis, which is where a portion of the protein is clipped off. In total, there are 12 coagulation factors numbered factors 1 to 12, but there's no factor 6. Most of these factors are produced by liver cells, and it turns out that producing coagulation factors 2, 7, 9, and 10 requires an enzyme that uses vitamin K.
Now, when vitamin K is absorbed from the digestive tract and travels to the liver, it's in its dietary form, and it's called vitamin K quinone.
An enzyme called quinone reductase takes electrons from NADPH and donates them to vitamin K quinone, converting it into the reduced form, which is called vitamin K hydroquinone. Then, vitamin K hydroquinone acts as a cofactor by donating its electrons to an enzyme called gamma-glutamyl carboxylase, which converts the non-functional forms of coagulation factors 2, 7, 9, and 10 into their functional forms. Gamma-glutamyl carboxylase adds a carboxyl group, which is a chemical group made up of one carbon and two oxygens, onto the end of glutamic acid residues on the proteins. After the carboxylation step, vitamin K is in an oxidized form where it can accept electrons, and it's called vitamin K epoxide.
Vitamin K epoxide gets converted back into vitamin K quinone by another enzyme called vitamin K epoxide reductase, or VKOR, which donates electrons to vitamin K epoxide using a thiol group.
In this fashion, a single molecule of vitamin K can be reused many times. As it turns out, the drug warfarin, which was first used as a rat poison, blocks the function of this enzyme, which blocks vitamin K from getting recycled, and as a result, factors 2, 7, 9, and 10 don't get activated. Now, let's take a closer look at the coagulation cascade to see where these coagulation factors play their respective roles. The coagulation cascade begins via two pathways, the extrinsic and intrinsic pathways. The intrinsic pathway starts when circulating factor 12 comes into contact with the surface of activated platelets or collagen. Activated factor 12 then activates factor 11, which activates factor 9, which activates factor 10. Factor 10 starts the common pathway where it activates factor 2, which activates factor 1 that builds the fibrin mesh. When factor 2 gets activated, it also activates 4 other factors: 5, 8, 9, and 13. Factor 5 gets activated and acts as a cofactor for 10. Factor 8 acts as a cofactor for factor 9, and factor 13 helps factor 1, or fibrin, form crosslinks. In the extrinsic pathway, exposed tissue factor activates factor 7, which activates factor 10 and starts the common pathway. So, without vitamin K, the loss of factor 7 means that the extrinsic pathway won't function. And without factor 9, the intrinsic pathway won't function. And without factor 10 and 2, the common pathway won't function. Warfarin is taken per oral, and it affects the extrinsic pathway first, since factor 7 has the shortest half-life, and it's the first coagulation factor to run out. Next, levels of factor 2, 9, and 10 also drop, causing inhibition of the intrinsic and common pathways. Since factor VII drops first, warfarin's efficacy is monitored using a blood test called prothrombin time, or PT, which is a measure of how well the extrinsic and common pathways are functioning. To perform this test, blood is drawn and the plasma is separated out by centrifuge. The plasma contains all the coagulation factors minus tissue factor, which is normally found within the blood vessel walls. Next, tissue factor is added to the plasma to trigger coagulation, and the time until the sample clots is measured. This measurement is called the prothrombin time, also abbreviated as PT, and it's compared to the control PT, which is the time it takes for the blood to clot in a healthy person. Now, the problem with PT is that there are multiple testing kits from different companies, and they all cause clotting at different rates. So, it's helpful to convert the PT into a standardized value called the INR, or International Normalized Ratio. This can be done by dividing our patient's PT by the control PT provided by the company. For example, if the person's PT is 22 seconds and the control PT is 11 seconds, their INR is 22/11, or 2. This means that that person's blood takes twice as long to clot compared to a healthy person.
A normal INR is 1.1 or less, but for someone taking warfarin, the usual goal is an INR between 2 and 3.
The main use for warfarin is in the prevention of disorders caused by blood clots. These include deep vein thrombosis, or DVTs, which is when venous blood clots called thrombi form in the deep veins of the legs. These thrombi can cause pulmonary embolism when they travel to the lungs and block off arteries.
In people with arrhythmias, particularly atrial fibrillation, the blood could pool in the heart, leading to blood clot formation.
These clots then get pumped out of the heart and make their way to the brain, where they block off cerebral arteries and cause strokes. Other common causes of blood clot formation in the heart include prosthetic heart valves and recent myocardial infarctions. Warfarin is the medication of choice for preventing these problems because it's taken per oral, so it's very convenient.
In terms of toxicity, the most common problem with warfarin is uncontrollable bleeding, most commonly in the GI tract. Bleeding can occur even at therapeutic levels, but the risk increases when INR is higher than 3. This can result when the dosage is too high, when other medications prevent warfarin from being metabolized, or when there is a polymorphism in the gene for VKOR leading to reduced function of the enzyme. Normally, warfarin is broken down in the liver by an enzyme called CYP2C9, which belongs to a class of enzymes called CYP450 oxidase.
Certain common medications like cimetidine, omeprazole, metronidazole, trimethoprim sulfamethoxazole, and amiodarone can inhibit this enzyme and cause warfarin to accumulate, thus increasing the INR. On the other hand, some medications like griseofulvin, barbiturates, phenytoin, and carbamazepine can enhance the activity of CYP450, which speeds up the metabolism of warfarin, and we get a subtherapeutic INR that's under 2. Therefore, it's extremely important to find out what medications a person is taking before initiating warfarin therapy.
Next, warfarin is contraindicated in pregnancy due to its teratogenic effects. It increases the risk of fetal hemorrhage, spontaneous abortion, bone deformities, and ophthalmologic abnormalities, such as optic neuritis.
Another problem is warfarin-induced skin necrosis, which is caused by tiny thrombi forming in the blood vessels in the skin. This happens because warfarin also inhibits the synthesis of the functional form of a vitamin K-dependent anticoagulation protein called protein C.
Normally, protein C combines with protein S to form a proteolytic complex which inactivates factor 5A and factor 8A.
Now, protein C has an even lower half-life than factor 7, so they are the first to disappear when someone takes warfarin. and hypercoagulation happens before the anticoagulation.
Patients with congenital protein C deficiency, meaning they have lower levels of protein C to start with, have an increased risk of warfarin-induced skin necrosis. So, to combat this, another anticoagulant called heparin is often given at the start of warfarin therapy. Heparin enhances the activity of another anticoagulation protein found in the body called antithrombin 3, which normally inactivates activated factor 2, or thrombin, and factor 10A. This balances things out until the anticoagulative effects of warfarin kick in, and it's referred to as a heparin bridge. If a person suffers a severe warfarin overdose, meaning they have an INR higher than 10, warfarin should be stopped and replaced with vitamin K. Vitamin K promotes the synthesis of new clotting factors, and therefore reversal of warfarin is slow. Now, if there's active bleeding, rapid reversal of warfarin is needed, so warfarin should be stopped, and the patient should be given fresh frozen plasma, or FFP, since it contains all clotting factors, or prothrombin complex concentrate, also known as PCC, which contains the coagulation factors 2, 7, 9, and 10, along with proteins C and S.
Alright, as a quick recap, warfarin is an anticoagulant that works by inhibiting vitamin K epoxide reductase for factors 2, 7, 9, 10, protein C, and protein S. It is administered orally as a long-term anticoagulation strategy to prevent clot formation.
Its toxicity profile includes bleeding, medication interactions, teratogenicity, and skin necrosis due to the initial transient hypercoagulation.
Anticoagulant medications help to prevent thrombi, or blood clots, from forming. These medications work by interfering with the normal function of proteins called clotting factors, in a chemical process called the coagulation cascade, or secondary hemostasis, where hemo refers to blood and stasis means to halt or stop. While the most common anticoagulants like warfarin and heparin act on multiple coagulation factors, in this video we're going to focus on anticoagulants that work on a single coagulation factor, either thrombin or activated factor 10. Now, before we discuss heparin in detail, we need to talk about the coagulation cascade, which is where heparin exerts its effect. The coagulation cascade starts via two pathways, the extrinsic and intrinsic pathways. The intrinsic pathway starts when circulating factor 12 comes into contact with the surface of activated platelets, or collagen. Activated factor 12 then activates factor 11, which activates factor 9, which activates factor 10. Factor 10 starts the common pathway where it activates factor 2, or thrombin, which activates factor 1 that builds the fibrin mesh. When factor 2 gets activated, it also activates 4 other factors, 5, 8, 9, and 13. Factor 5 gets activated and acts as a cofactor for 10. Factor 8 acts as a cofactor for factor 9, and factor 13 helps factor 1, or fibrin, form crosslinks. In the extrinsic pathway, exposed tissue factor activates factor 7, which activates factor 10 and starts the common pathway. Now, the most common point of clot regulation is when a coagulation factor called thrombin is produced. Thrombin, or activated factor 2, is a very important clotting factor because it has multiple pro-coagulative functions. Think of thrombin as the accelerator on a car, the pedal that takes secondary hemostasis from 20 miles per hour to 100 miles per hour. First, thrombin binds to receptors on platelets and causes them to get activated. Activated platelets change their shape to form tentacle-like arms that allow them to stick to other platelets. Second, thrombin activates two cofactors, factor 5, used in the common pathway, and factor 8, used in the intrinsic pathway. Third, thrombin proteolytically cleaves fibrinogen, or factor 1, into fibrin, or factor 1A, which binds with other fibrin proteins to form a fibrin mesh. And finally, thrombin proteolytically cleaves stabilizing factor, or factor 13, into factor 13A. Factor 13A combines with a calcium ion cofactor to form cross-links between the fibrin chains, further reinforcing the fibrin mesh. The direct thrombin inhibitors and the direct factor 10A inhibitors inhibit the coagulation cascade by binding to their corresponding coagulation factors after they've been activated. The direct thrombin inhibitors can bind to thrombin that's in the circulation, and those already attached to a forming clot. Factor 10A inhibitors have the same function on 10A. However, it has an overall greater effect on anticoagulation, since it's higher up in the coagulation cascade. So each molecule of the medication can prevent multiple thrombins from being activated by factor 10A. Now, in terms of laboratory parameters, direct thrombin inhibitors prolong thrombin time and have less effect on prothrombin time, or PT, which assesses the extrinsic and common coagulation pathways, and partial thromboplastin time, or APTT, that assesses the intrinsic and common coagulation pathways. Direct factor 10A inhibitors prolong both PT and APTT, but have no effect on thrombin time. However, both classes of direct factor inhibitors do not require routine monitoring. Now let's discuss each class of medications in more detail, starting with the direct thrombin inhibitors, like bivalirudin, lepirudin, and argatroban, which are given intravenously, desirudin, which is given subcutaneously, and dabigatran, which is given per oral. This class of medications was initially isolated from the saliva of leeches due to its anticoagulant effect. Although they're not as frequently used as heparin, they can be used as a second-line medication in people with a history of deep vein thrombosis to prevent pulmonary embolism, or atrial fibrillation to prevent strokes. Direct thrombin inhibitors are especially useful when heparin causes an adverse reaction called HIT, or heparin-induced thrombocytopenia. HIT occurs when some people produce antibodies, which bind to heparin bound to a protein on the surface of platelets, called platelet factor 4. The complex antibody heparin platelet factor 4 leads to platelet activation and aggregation, hence thrombosis. There is also destruction of platelets by cells of the spleen called macrophages, resulting in a low platelet count. These medications are also used in combination with antiplatelet agents like aspirin and clopidogrel to prevent clot formation in patients undergoing coronary artery surgery. In terms of toxicity, direct thrombin inhibitors are associated with GI symptoms like dyspepsia and gastritis. However, the most dangerous thing is the risk of increased bleeding when taken in excess. This could lead to uncontrollable internal bleeding from simple falls or trauma. Thankfully, a reversal agent called idarucizumab, an antibody, which binds to and inactivates dabigatran, can be administered to people who experience uncontrolled bleeding from this medication. For the other direct thrombin inhibitors, there's no reversal agent available. Prothrombin complex concentrate, also known as PCC, which contains the coagulation factors 2, 7, 9, and 10, along with proteins C and S, or antifibrinolytic agents, like tranexamic acid, can be used. Other common toxicities with these medications include hypersensitivity reactions, especially with lepirudin and bivalirudin. Direct thrombin inhibitors should not be discontinued suddenly, as it can lead to increased thrombosis and risk of strokes. Now, the direct factor 10A inhibitors like apixaban, edoxaban, and rivaroxaban are all per oral medications. They have XA in their name, which should help you remember that they act on factor 10A. Factor 10A inhibitors are becoming more commonly used for the treatment and prevention of deep vein thrombosis, pulmonary embolism, and stroke prevention in patients with atrial fibrillation. They're becoming a useful alternative to the anticoagulant medication warfarin, because they don't require laboratory monitoring, have fewer drug interactions, and have a rapid onset of action. The main toxicity of these medications is also uncontrollable bleeding. The FDA just approved andexanet alpha as a reversal agent for factor 10A inhibitors. Andexanet alpha binds to factor 10A inhibitors, inhibiting them from binding to factor 10A. Furthermore, they're metabolized by an enzyme called cytochrome P450. So any medications that inhibit this enzyme, like cimetidine, metronidazole, trimethoprim, or sulfamethoxazole, And amiodarone can cause the accumulation of these medications in the body, leading to bleeding. Alright, so now let's make a simple and fun mnemonic that'll help you efficiently memorize these pharm facts. Let's have a hitchhiker sticking out a hand with a huge thumb for the direct thrombin inhibitors. And further away, there's a tent for factor 10A inhibitor. The hitchhiker's pet reindeer, Rudolph, represents the 3 drugs that end in rudin, like bivalurudin, lepirudin, and desirudin. On its back, it's carrying the hitchhiker's 2 Gatling guns. Argatroban is the single-barreled variant, and dabigatran is the double-barreled variant, where the barrels are big lips to help you remember this is the only per-oral medication in the class. The hitchhiker was practicing his shooting earlier, and there's a target nearby with bullet holes in it to help you remember these medications are used by people with heparin-induced thrombocytopenia, or HIT. Finally, let's put 2 darts in the barrels of the dabigatran gun to represent idarucizumab, which can inhibit the medication if it causes uncontrolled bleeding. For the direct factor 10A inhibitors, let's go back to the tent, which belongs to the members of a rock band, or Rox band, which represents the medications with exaban in their name, like rivaroxaban and apixaban. The lead singer has a huge lip to help you remember these medications are per oral. A giant chrome-colored cell is sneaking up to engulf the band, which represents the cytochrome P450 that metabolizes these medications. Finally, let's put a banner above them that says "Make Music, Not War," since they can be used as an alternative to warfarin. Alright, as a quick recap. Direct coagulation factor inhibitors are anticoagulants used for prevention of serious conditions like strokes and pulmonary embolism. Direct thrombin inhibitors like bivalurudin, lepirudin, desirudin, argatroban, and dabigatran can be a useful replacement for heparin in people with a history of HIT. Direct factor 10A inhibitors like rivaroxaban and apixaban are becoming more commonly used as an alternative to warfarin. Both classes of medications have uncontrolled bleeding as their main toxicity, but the effects of dabigatran and factor 10A inhibitors can be reversed by adarucizumab and andexanet alpha, respectively. But wait, there's more! Here's a mind map with all of the mnemonics. Go ahead and pause the video so you can test yourself to see what you remember. Stay tuned for the answers after the credits. Anticoagulant medications are used to prevent blood clots from forming. These medications work by interfering with the normal function of plasma proteins called coagulation factors, which take part in secondary hemostasis, where hemo refers to blood, and stasis meaning to halt or stop. In this video, we're going to focus on heparin, which works by indirectly inhibiting 2 clotting factors called thrombin and factor 10A, by binding to and enhancing the activity of an anticoagulant protein called antithrombin 3. Now, before we discuss heparin in detail, we need to talk about the coagulation cascade, which is where heparin exerts its effect. The coagulation cascade starts via 2 pathways, the extrinsic and intrinsic pathways. The intrinsic pathway starts when circulating factor 12 comes into contact with the surface of activated platelets, or collagen. Activated factor 12 then activates factor 11, which activates factor 9, which activates factor 10. Factor 10A starts the common pathway, where it activates factor 2, or thrombin, which activates factor 1 that builds the fibrin mesh. When factor 2 gets activated, it also activates 4 other factors, 5, 8, 9, and 13. Factor 5 gets activated and acts as a cofactor for 10. Factor 8 acts as a cofactor for factor 9. And factor 13 helps factor 1, or fibrin, form crosslinks. In the extrinsic pathway, exposed tissue factor activates factor 7, which activates factor 10 and starts the common pathway. Now, the most common point of clot regulation is when a coagulation factor called thrombin is produced. Thrombin, or activated factor 2, is a very important clotting factor, because it has multiple procoagulative functions. Think of thrombin as the accelerator on a car, the pedal that takes secondary hemostasis from 20 miles per hour to 100 miles per hour. First, thrombin binds to receptors on platelets and causes them to get activated. Activated platelets change their shape to form tentacle-like arms that allow them to stick to other platelets. Second, thrombin activates two cofactors, factor V, used in the common pathway, and factor VIII, used in the intrinsic pathway. Third, thrombin proteolytically cleaves fibrinogen, or factor I, into fibrin, or factor Ia, which binds with other fibrin proteins to form a fibrin mesh. And finally, thrombin proteolytically cleaves stabilizing factor, or factor XIII, into factor XIIIa. Factor XIIIa combines with a calcium ion cofactor to form cross-links between the fibrin chains, further reinforcing the fibrin mesh. Since thrombin is so crucial to coagulation, it makes sense that it serves as the main target of antithrombin 3, which is one of the body's anticoagulation proteins. Now, antithrombin 3, sometimes just called antithrombin, is a protein made by the liver and released into the blood, where it binds both thrombin and factor Xa in the common pathway. The thrombin in the blood can bind to antithrombin and become unavailable. Antithrombin also binds to active factor X, which is a pivotal coagulation protein that converts prothrombin into thrombin. Antithrombin also inhibits factor 7, 9, 11, and 12, although with much less affinity. Heparin is a carbohydrate molecule with a pentasaccharide chain followed by a tail made of glycosaminoglycans. Heparin can be unfractionated or fractionated. Unfractionated heparin refers to heparin derived physiologically, usually from pig intestine, and is a mixture of high molecular weight heparins, or HMWH, as well as low molecular weight heparins, or LMWH. HMWH has a longer glycosaminoglycan tail, while LMWH has a much shorter tail. Fractionated heparin is created when unfractionated heparin undergoes a process where the HMWH gets depolymerized, meaning part of their tail gets chopped off, so it only consists of LMWH. The length of the tail is crucial for the function of these two types of heparin. Both high and low molecular weight heparins can bind to the antithrombin 3 via the pentapeptide region to increase its activity in inhibiting factor Xa. However, in order to increase antithrombin 3's activity against thrombin, the thrombin needs to bind to the long tail of the heparin, meaning only high molecular weight heparin has an effect on thrombin. Compared to unfractionated heparin, low molecular weight heparin like enoxaparin and dalteparin have better bioavailability and have a 2 to 4 times longer half-life. Additionally, low molecular weight heparin does not require laboratory monitoring because it does not affect thrombin. Another medication that shares these features is fondaparinux, which is a synthetic molecule similar to low molecular weight heparin, but only contains the pentasaccharide chain. Heparin is administered intravenously or subcutaneously to people for short-term anticoagulation, and immediate anticoagulation because of its rapid onset, usually within seconds, and chemical makeup. Because of its direct route into the blood and immediate anticoagulant effects, it's used for many acute problems. In fact, it's the medication of choice during an acute deep vein thrombosis, preventing post-operative deep vein thrombosis and pulmonary embolism, maintaining extracorporeal circulation during open-heart surgery, and renal hemodialysis. For chronic management, warfarin or direct oral anticoagulants, or DOACs, are usually preferred since they can be taken per orally and the person can take the medication home. However, heparin is the preferred anticoagulant in pregnancy because unlike other anticoagulants like warfarin, it does not cross the placenta and therefore it does not have any teratogenic effects. Since heparin primarily operates on factors in the common and intrinsic pathway, a laboratory value called the APTT, or activated partial thromboplastin time, is used to measure its efficacy. The APTT measures the speed at which blood clots via the intrinsic and common coagulation pathways. To perform this test, blood is drawn from a person and placed in a test tube. Next, the sample is separated by centrifuge into plasma, which contains the coagulation factors. Next, a contact activator, like silica or cellite, which mimics the surface of a platelet, gets added to the sample to trigger the activation of the intrinsic pathway. The time until the sample coagulates gets measured. A normal APTT is between 30 seconds and 40 seconds. The APTT is approximately 50 to 90 seconds, or 1.5 to 2.5 times the person's baseline value. If a person was given too much heparin, then the APTT can rise to values greater than 100 seconds, and the person might suffer internal bleeding. In these situations, a reversal agent called protamine sulfate can be given. Protamine sulfate is a positively charged molecule, and so it can bind to the negatively charged heparin, rapidly inactivating its anticoagulant activity. Another toxicity to be aware of is called HIT, or heparin-induced thrombocytopenia. Thrombocyte referring to platelets, and penia meaning small or little, so thrombocytopenia means low platelets. Heparin binds to a protein on the surface of platelets called platelet factor 4. This complex is immunogenic, meaning it can cause the immune system to produce proteins called antibodies that bind the complex. As a result, antibody heparin platelet factor 4 complex forms, and leads to platelet activation and aggregation, hence thrombosis. There's also destruction of platelets by cells of the spleen, called macrophages, resulting in a low platelet count. HIT happens in 5 to 10% of patients treated with unfractionated heparin, and the risk is lower with LMWH. It typically develops 5 to 10 days after the initiation of heparin, but can develop within the first 24 hours if the patient has been exposed to heparin in the previous 1 to 3 months, since antibodies that target heparin platelet factor 4 complex are already formed. If HIT happens, the heparin should be stopped and the person switched to a different anticoagulant, like direct thrombin inhibitors, which includes medications like argatroban, bivalirudin, and dabigatran. Other toxicities associated with heparin include an increased risk of osteoporosis, as well as interactions with other medications that enhance anticoagulation like aspirin, ibuprofen, and warfarin. Heparin has been known to have decreased anticoagulation effects with medications like digitalis, tetracyclines, antihistamines, and nicotine. Alright, as a quick recap. Heparin works by lowering the activity of two clotting factors called thrombin and factor Xa, by binding to and enhancing the activity of a protein called antithrombin 3. Heparin can be unfractionated or fractionated, which is also called low molecular weight heparin. Unfractionated heparin inhibits both factor Xa and thrombin, while low molecular weight heparin only inhibits factor Xa. Both types are utilized for short-term immediate anticoagulation for diseases like acute pulmonary embolism, deep vein thrombosis, as well as surgical prophylaxis. Heparin's main toxicity profile includes its increased risk of bleeding, HIT, and osteoporosis.